Today, I'm delighted and glad to present Professor Bugianesi's seminar that is entitled Lean MASLD Facts or Function. And before letting her start her presentation, let me share with you some highlights of Professor Bugianesi. She holds a prestigious position of full professor of gastroenterology within the Department of Medical Sciences at the University of Torino. Additionally, she serves as scientific director and deputy director of the Department of Medical Science and directs the Laboratory of Molecular Hepatology and Gastroenterology. Alongside these academic roles, she actively engages clinical activities within the gastroenterology and internal medicine. With over 2 decades of dedicated experience in the field of MASLD, Professor Bugianesi has an impressive publication record and has made an undeniable contribution in the field. Personally, I consider that she stands as a respected authority in the field and serves as an inspiring figure of women in science. So thank you very much for accepting our invitation. We are immensely grateful to you for accepting our invitation and to share your insights with us. So please, you are free to share your screen and enjoy all the audience the presentation.
First, let me thank Natalia and Claudio because it is really a pleasure. And okay, so let's share the presentation. Can you see that?
Yes, we can see it.
Okay. So indeed, it was lean MASLD facts or function, because somebody believes lean MASLD does not exist, but they do exist actually. So these are my disclosure. Let's just revise the new nomenclature that's been adopted at the end of last year after a Delphi process. So the metabolic dysfunction-associated steatotic liver disease, or MASLD, is defined by the presence of hepatic steatosis in conjunction with at least one cardiometabolic risk factors, meaning the components of the metabolic syndrome, and no other discernible causes. The threshold for alcohol consumption still stays at 20 grams a day for women, 30 grams a day for men. Metabolic dysfunction-associated steatotic liver disease stays under the umbrella of steatotic liver disease, which also include alcohol-associated liver disease and the new entity, the MASLD-ALD overlap, where people have both cardiometabolic risk factor and moderate or more than moderate alcohol consumption, but nevertheless lower compared to the threshold for alcoholic-associated liver disease. Then we have single etiology steatotic liver disease, such as drug-induced liver injury, monogenic disease, miscellaneous, and cryptogenic disease. Having said that, this is first of all, the definition of lean MASLD. It is different according to the geographic area because the definition of lean is for a BMI lower than 25 in Caucasian and lower than 23 in Asian. And the prevalence, as you can see in this figure, overall of lean people within the MASLD subjects, it's 40% with geographical variation. The lowest is usually in USA and the highest in the Southeast countries, but also in Italy. I would say that 1/4 of the patients are lean, and the same is true also for Spain, Sweden, Denmark, and India, of course, Bangladesh, and Australia. Now, the common mistake that is usually being made with these people is that they attribute their disease to alcohol consumption. This is something that shouldn't be done. How can a lean subject get MASLD? Actually, there are several ways, and this is just, how can I say, the number of causes of MASLD. The most common, the one that are included into the current MASLD definition, are the first two. So the metabolically obese normal weight subject and environmental. Then there is congenital and acquired lipodystrophy. There is a genetic contribution that can go across all these categories, particularly for PNPLA3, but there are also more uncommon congenital defects of metabolism. Then there are endocrine disorder, polycystic ovary syndrome, hypothyroidism, growth hormone deficiency, and drug-related, for example, amiodarone, methotrexate, tamoxifen, corticosteroids, and other. And finally, jejunal-ileal bypass, starvation, and total parenteral nutrition. By going through these causes one by one, first of all, we must say that BMI is really a poor marker of insulin sensitivity. This is a diagram from the AGE study group where they plot the body mass index toward the whole body insulin sensitivity assessed by the euglycemic hyperinsulinemic clamp, so the most sensitive way to assess insulin resistance. But if you look at a BMI between 20 and 30, and you cross with your whole body insulin sensitivity, then you can see that there is a small group of metabolically healthy obese, that is, those with a BMI higher than 30, but definitely with a high insulin sensitivity. And on the contrary, there is a group of the so-called metabolically obese normal weight, where their BMI is lower than 25, but they are definitely have a low, very low insulin sensitivity. So what's the problem? The problem is that we cannot attribute metabolic health just based on BMI, because it depends basically on the metabolic flexibility of the adipose tissue, on the quality of your adipose tissue, the expandability, the function, the production of pro-inflammatory or anti-inflammatory adipokines, such as adiponectin. So we have the spectrum of conditions starting from metabolically healthy or lean, and then metabolically unhealthy lean. Metabolically unhealthy obese, of course, is the most common category, but we have also a small group of metabolically healthy obese. And this is the difference between the metabolically healthy obese versus the metabolically obese normal weight. So the lucky MHO subject have normal insulin sensitivity, low visceral adiposity, no liver fat, high HDL cholesterol, low triglyceride, and high physical activity energy expenditure. On the contrary, the poor MW subject have altered insulin sensitivity. They are lean, but they have a high fat mass, a low lean body mass, low muscle, high visceral adiposity, high liver fat, high triglyceride, low HDL cholesterol, high blood pressure, low physical activity, they are very lazy, and a high risk for type 2 diabetes and cardiovascular disease. So these are in general all the risk factors for MASLD in different studies. Triglyceride, hypertriglyceridemia is one of the most common features that you can find in this lean subject. You can also find an elevated OMA index, of course, an increased waist circumference, again, abdominal obesity, and often you can also find impaired fasting glucose. This is a study that we did a while ago in 2005, where we assessed insulin resistance in various tissues by a two-step euglycemic hyperinsulinemic clamp in people without type 2 diabetes and without obesity. And there was half of these people were just overweight, the other half were lean. But despite being lean, this subject had adipose tissue insulin resistance. The red dots are the MASLD, MASLD, while the blue are the controls. So they have an impaired suppression of plasma-free fatty acid by insulin. They release much more free fatty acid from the adipose tissue. They had a degree of hepatic insulin resistance compared to the controls, and this means that they were producing more glucose output compared to the controls, and they have a lower muscle insulin sensitivity compared to controls, meaning that they were less able to incorporate glucose as glycogen in the muscle. So the second cause is environmental, and this is something that is very important, and you should always look for it when you see a lean patient with a fatty liver. So this is a landmark paper, again published a while ago, when they took some 15 healthy subjects and they randomized first to a high-fat diet, so a McDonald's for 15 days, and then switched to a vegan diet. And you see that after just 15 days, 2 weeks, their liver fat content increased to 35%, and their fasting insulin level were increased as well. When they were switched to the low-fat diet, of course, they decreased their body fat, they decreased their insulin, but actually less efficiently compared to the previous diet, because the most detrimental factors are the ones that are also the most effective, the most rapid, I would say. Soft drink consumption. This is again something that you should always look for, particularly in adolescents and children. If you look at soft drink consumption in MASLD compared to controls, you see that 43% of added sugar comes from soft drinks compared to 8% in control. And overall, the intake of soft drink is 5-fold higher in MASLD subject compared to controls. Of course, this increased fructose actually intake can increase the prevalence of MASLD independent of the metabolic syndrome. And this is another study, again, 2010, so a while ago, that established that there is a link between the number of servings of cans of soda and the liver damage. And it is different if you are younger than 48 or older than 48. If you are younger, then the number, the servings higher than 7 per week is linked to an increase in fibrosis, even after adjustment for all the other confounding factors. If you are older than 48, of course, you have still the increased risk of fibrosis, but you also have an increase of steatosis, which is not true in the younger population. The problem with fructose, which is, the main sugar in all the soda drinks, is that fructose increases de novo lipogenesis. And de novo lipogenesis produces only saturated fatty acid that could induce both inflammation and insulin resistance. And they can also alter the microbiome and increase gut permeability. So this is congenital acquired lipodystrophy, which is not a common cause of MASLD, but actually it is common in people with HIV on antiretroviral therapy. So this is normal adiposity. This is a CT scan. You see all the adipose tissue is subcutaneous. These are the thighs. And again, you see the subcutaneous adipose tissue and the muscle. This is generalized obesity, where there is all this big increase in subcutaneous and visceral fat, and here in the thigh as well. But look at this lipodystrophy. You see that there is no subcutaneous fat at all. So all the fat accumulates in ectopic sites, meaning in the liver, but also in the visceral area, but also in the muscle. You see how white is this muscle because it's infiltrated with lipid-filled myocytes. Then let's move to the genetic causes. First, the most common, of course, the genes that are usually linked to MASLD. The first one is the PNPLA3 with the variant G, so heterozygosity CG or homozygosity GG, which is associated with increased hepatic triglyceride levels and increased risk of MASH, hepatocellular carcinoma, and cirrhosis. Then there is the missense variant in TM6SF2CT, where the homozygosity for TT is the variant, that dissociated NAFLD from cardiovascular disease because those with the TT homozygosity are at high risk to develop MASLD, but a low risk of developing cardiovascular disease because they trap all the triglyceride within the liver, so the lipid levels are very low. Then there is the MOAD-CT variant, which has an effect on both alcoholic and non-alcoholic, and the most recent HST17B13 variant that, on the contrary, confers protection for limb damage in NAFLD. All these variants actually have metabolic effects. So they impact on triglyceride, cholesterol, they are involved in stroke, in diabetes, gallstone, gout, and so on. However, it is not always true that lean subjects with MASLD have a genetic variation in PNPLA3 or in TM6SF2. This is actually, one of the largest studies where they tested all the variants, so PNPLA3, TM6, and YT, ApoC3, HSD, and so on, according to BMI classes, lean, overweight, and obese. And actually, this is the wild type. The yellow is the wild type, the green is the heterozygote, and the blue is the homozygote. The proportion of the circle means how high is the proportion of people with that mutation. In particular, if you look at the blue, which is the homozygosity, there is a higher number of PNPLA3 in lean subjects compared to overweight and obese, but there is, on the contrary, a higher percentage of TM6SF2 in overweight compared to obese and lean. Actually, this is one of the few studies where they found a difference because many other studies before and after this one did not find any difference in the distribution of PNPLA3 and TM6SF2. But we did find something when we were analyzing subpopulation. So we were performing risk stratification by phenotype, so lean, obese, and at risk, which is the one with the most important liver damage, based on PNPLA3 genotype. And we were able to show that this homozygosity has a major impact on a definite at-risk group, which is females older than 50 and non-obese. And these females older than 50 and non-obese at higher risk are at higher risk of longitudinal liver events. Of course, there are also epigenetic modifications besides the environmental factor. One important issue is the intrauterine environment. sorry. Actually, we were the first, along with Valerio Nobili, to find out that intrauterine growth retardation is associated with more severe insulin resistance and disease activity on histology, independent of BMI in children with MASLD. So at an average age of 11 years, most children with fatty liver born small for gestational age were insulin resistant despite a normal BMI and the lower prevalence of metabolic abnormalities. I beg your pardon, but I need some water. Sorry. Okay, sorry about that. Another different issue actually is the gut microbiota. Actually, there is a difference in the composition and in the percentage of several species in gut microbiota which are associated with lean NAFLD. And actually, this may be one of the reasons why there is a different metabolic adaptation that can impact on the onset and progression of fatty liver. So if I can make a summary of what I was saying so far, if you look at lean individual with MASLD compared to healthy lean individual, they have an unhealthy lifestyle because probably they have more often an healthy diet, they have a low physical activity, probably they have gut dysbiosis, they have some epigenetic factor. Then on these factors, there is an overlap of the polygenic effects of multiple SNPs, first of all PNPLA3, which is not always being found. And these lead to metabolic dysfunction and a larger visceral adipose tissue compared to a low subcutaneous adiposity and the presence of sarcopenia. Then let's move to the less common genetic causes, but that you should have in mind if all the search for insulin resistance and cardiometabolic risk factor is negative. So familial hypobeta lipoproteinemia is an autosomal codominant disorder characterized by ApoB less than the 50th percentile, and so an LDL cholesterol very low, between 20 and 50 milligram deciliter. You can recognize these people because they have very low cholesterol levels, blood cholesterol levels. There are over 60 mutations, and the problem with FHLB is that hepatic steatosis due to a defective export of triglyceride from the liver, and the pure form is not associated with muscle or adipose tissue insulin resistance. But of course, in real life, there is always a lot of overlaps, so you may have both. There have been reports of cirrhosis and hepatocellular carcinoma associated with FHLB that suggest that these patients should be monitored, particularly those with the ApoB67 mutation. Then there is the famous lysosomal acid lipase LAL deficiency. Actually, pediatricians look at this patient. The problem with the disease is the LAL enzymatic activity is reduced to 1 to 12%, and this leads to lysosomal storage disease. These subjects, these poor children, have very high cholesterol levels, like 5 years old, 350 milligram deciliter of cholesterol. They have alteration in the liver and spleen, sometimes splenomegaly. But they have also alteration in the kidney, brain, nerves, heart, skin. Sometimes they have a typical faces, typical eyes. And they die because of liver disease, because of cirrhosis, but also because of cardiovascular disease, because they have this huge unfavorable lipid profile. Fortunately, there is a therapy, the sebelipase. The sebelipase is an enzyme replacement treatment that should be given and reverse all the features of this disease. Then the last two, I'm not going to go through, I just mentioned the drug-related and those related to jejunoidal bypass or starvation. But to, again, stop and make a suggested approach to this lean MASLD, most of these fall into the MASLD category of those with cardiometabolic disease. So look at the cardiometabolic criteria. You need at least one cardiometabolic criteria plus hepatic steatosis. If you are unable to find even one of these cardiometabolic criteria, you have, of course, to exclude all the other diseases that can express with a fatty liver, for example, Wilson disease, sometimes autoimmune hepatitis, and of course, hepatitis C. But then you go to the more rare diseases, such as those with serum lipid abnormalities, so hypobeta lipoproteinemia, LAL deficiency, or selective loss of adipose tissue, for example, like lipo-dystrophy, and even more uncommon when you have muscle weakness or neurological symptoms and elevated lactate level, you can have mitochondrial disorders. Then the second question is how to manage lean subject with NAFLD. Sorry for the switch between MASLD and NAFLD because these slides were made in different times. So although overall this population is more metabolically healthy compared to the obese population, but nevertheless, they still have the criteria of the metabolic syndrome. And this is the proportion of patients with each of the criteria of the metabolic syndrome according to BMI. You see, increased waist circumference, 79% of overweight obese compared to 33% on lean and so on. But still they do have this feature and they are insulin resistant compared to lean healthy. What happened to these people? This is a longitudinal study where we compare the incidence, the progression of the cardiometabolic as well as liver-related outcomes in lean versus non-lean, that is overweight and obese. So after a follow-up of 94 months, you see that the incidence of diabetes in lean is the orange and in non-lean is the green. The incidence of liver decompensation, the incidence of HCC, or cardiovascular events, and of liver cancer was no difference between lean and non-lean. They were still developing the same kind of complications. Why this? Because, these patients initially are more metabolically flexible compared to the overweight and particularly compared to the obese. But in the time, metabolic flexibility is lost, and so the clinical outcome is going to be the same. And these are the long-term prognosis related to overall mortality or liver-related mortality. The controls is the gray line, and the dotted gray is the lean. Now, there is no difference from overall mortality with the general population, but if you look at liver-related at survival, free of liver or severe liver disease, actually the one who is going worse are the lean patients, even worse or equal to the obese patients. So along the time, these are 40, almost more than 30 years of follow-up, they develop more liver disease compared, of course, to the general population overweight and at the same extent of obese MASLD. And these are all another meta-analysis on the long-term outcomes of these non-obese, lean, and obese MASLD. And if you look at the causes of mortality, first of all-cause mortality is 12 per 1,000 persons a year. Liver-related mortality is 4 per 1,000 persons a year. Cardiovascular-related mortality is again 4. New-onset type 2 diabetes, 12. New-onset cardiovascular disease, 18. New-onset hypertension, 56. So really, these are these metabolic people that only apparently look normal. What about the therapy, actually? The diet. Of course, it is difficult to prescribe a diet to a lean subject. You should first reduce fructose intake, sugar, soft drink, increase physical activity that decreases visceral fat independent of body weight. But if you look at this trial, where they gave the same kind of diet for a 12-month lifestyle intervention to people with BMI higher or lower than 25, then the percentage of patients with remission of MASLD, if they lose more than 10% of their initial body weight, is even better of those with a BMI equal or higher than 25, meaning that the diet is anyway working in these people. So in the end, I think that we should not talk about lean, overweight, or obese. We should just stratify as at-risk phenotype based on several factors, based on genetic background, gut microbiome, bioacid composition, nutritional habits, physical exercise, and so on, because the rate of complication is not just determined by the BMI and can be exactly the same independent of body weight. And so in conclusion, lean patients with MASLD should be screened for the presence of insulin resistance, genetic endocrine disorder. The pathophysiological mechanisms are not totally understood. They may include a dysfunctional adipose tissue, altered body composition, genetic mutation, epigenetic changes, and pattern of gut microbiota. Although generally with a more favorable metabolic profile when compared to obese, the lean patients can develop the same full spectrum of liver damage and also cardiovascular damage. It is not a benign disease. General recommendations include an adoption of a healthy lifestyle, but the guidelines, unfortunately, do not provide much information as to whether and what extent, given the harder correction of underlying risk factors. And so I finished, and I thank you so much for your attention.
Thank you very much, Elisabetta, for your presentation.